Okay. Good morning, everyone. Nice to see you again in this second day. Okay, and this part, I'll share some experience of the basic abdomen ultrasound in Covalent kidney. This topic is actually a really big topic, so I'll try to finish this in 20 minutes. Okay, so I'll start from the Covalent part. And another question is here. So if you want to answer and get a small gift, just listen. It's just a simple question. What do you see in this image? A, normal gallbladder. B, gallbladder stone. C, acute cholecystitis. And D, biliary tract dilation. Which one? A. Okay. Yes. No problem. The first question is always the easiest question. Okay. Small gift. Okay, so to image the gallbladder, we know the gallbladder is on the right side of the abdomen. So you just place your transducer below the costal margin of the right side abdomen and try to put the pointer, the transducer marker heading, pointing to your head, and just slide the transducer along the costal margin until you find it. And if you see anything just like this one, like the gallbladder one, the gallbladder looks like an echoid circular structure in this area. But if you see it, you may stop your transducer and rotate or tilting slowly to make sure you see the correct long axis view. As you see the long axis view, you stop your transducer and rotate and tilt it, finding the correct long axis view, and you can turn your transducer 90 degrees counterclockwise to see the axial view, the short axis view. So making sure your transducer pointer to the patient's right. This is the transverse view looks like. Actually, gallbladder just look like a ball or a circular structure in a echoid. So it's the normal appearance. And in this stage, you have to tilting your probe to see the whole gallbladder, because there may be some small stone or polyp hiding in one angle of the gallbladder. If you just see a cut, you may not see the whole gallbladder and miss something. So this is the portal vein and common bile duct. In this chapter, I put the most slides in the cholecystitis and gallstone. Just this one, a little information about the common bile duct, because I think to find the common bile duct actually is quite difficult, a little difficult for a beginner. So if you want to find it, you have to find the portal vein first. Portal vein is just the in the longitudinal view, you'll see maybe the biggest vessel. It's the IVC, and the upper is the portal vein. The common bile duct is just located on the portal vein, just here. And these two is another two vessel. To differentiate this each to other, the best way, the counting way, is to use the Doppler to see it has flow in it or not. If there is no flow in it, it's the common bile duct, and it's the flow in it, you can see it's the vessels. To measure a common bile duct, you need to measure in the inner diameter. It's different to the delta mentioned yesterday. Okay. I think everyone is remember that the delta is measured in the outer diameter, but common bile duct is measured in the inner diameter. It's different. Okay, so what do you see in this image? The best distribution. A, normal gallbladder. B, the gallbladder stone. C, acute cholecystitis. D, biliary tract dilatation. The same options, but different answer, of course. And anyone? Okay. Also, right. Quite simple question. Thank you. Okay, so gallstone is mobile and hyperechoic structure in the gallbladder. You can see it's just located here. And its character is there may be a hypoechoic occlusive shadow behind the gallbladder stone. Because this, the ultrasound beam will stop transmission by the gallstone because it's a hard material. And the machine falsely interprets that the area behind the gallstone is darker than nearby. So you see the occlusive shadow here. However, the gallstone is variable in size. So if you see a tiny gallstone, especially maybe less than 4 millimeters, it will not cause the occlusive shadow. So it will be hard to differentiate with the gallbladder polyp. So to differentiate each other, maybe you have to move your patient, maybe from supine position to left decubitus, and see the structure is, if it is still here, still there. If the structure is still there, it's the possibility of the gallbladder polyp is larger than gallbladder stone, because the gallbladder stone is a mobile structure. It can roll in the patient's gallbladder. So if he moves his position, the gallbladder will, the gallstone will move. Okay, let's see. Mid-aged female with right upper quadrant pain. Might see several hyperechoic structure in the gallbladder and see several occlusive shadow behind the gallbladder. It's a typical gallstone with the occlusive shadow. You can see it then once. Gallstone, multiple gallstones with occlusive shadow. This is the portal vein here. The next one is the also gallstone with a bigger gallstone. So you can see the occlusive shadow is more prominent. One bigger stone, more prominent occlusive shadow. So this is the last question. What is the best description of this image? You can see the gallstone, right? But there are another abnormal findings in this image. So A, normal, B, gallstone, C, acute cholecystitis, and D, biliary tract dilation. Which one is the best description of this image? Anyone? So, acute cholecystitis is right. Later, please. A little far. Okay. Acute cholecystitis is a common disease we see, and the ultrasound is the often is the main goal. We do the ultrasound for gallbladder. We just want to find if the acute cholecystitis. The acute cholecystitis have several characteristic findings. One is the gallstone. In emergency room, if you find a patient with acute cholecystitis but no gallstone, maybe we'll call it a calculus cholecystitis. But the opportunity for finding this kind of patient is really low, because this kind of patient often found in the ICU room or critical illness patient. So if this is a fresh patient walking to your ER, and please suspect that this is acute cholecystitis with gallstone, and don't think that without gallstone, but he had cholecystitis. And the second finding is the gallbladder wall thickness. Gallbladder wall thickness is larger than 3 millimeter. That's the main finding of the acute cholecystitis. And third is sonography Murphy sign. Sonography Murphy sign means that the traditional we did the Murphy sign by place your hand and on the side you think that the gallbladder is and press it right. But sonography Murphy sign is use your transducer and see the gallbladder where it is and just press the gallbladder by your transducer. And if you done this and the patient maximal tenderness was repeated by this action, this means the positive sonography Murphy sign. So it's highly predictive of acute cholecystitis. The third is the pericholecystic fluid. We will see some hypoechoic region around the gallbladder. The last one is transverse diameter larger than 4 to 5 centimeter. Let's see first case. You can see the gallstone, gallbladder wall thickening, and pericholecystic fluid in this case. All you can see, gallstone, wall thickening, and then the pericholecystic fluid. So remember, there are some conditions make the gallbladder wall thickening. For example, the patient has ascites, or congestive heart failure, or hepatitis. This kind of condition will make the patient, the gallbladder wall thickening, but not acute cholecystitis. So remember, if you want to measure the gallbladder wall, measure the anterior wall, this side, near the patient's liver, this side, not this side, this side. Okay, here's the gallbladder part summary. Remember the morphology of gallstone, the hyperechoic and acute shadow. And the second is the acute cholecystitis, the gallbladder wall thickness, and the sonography Murphy sign, and pericholecystic fluid. Okay, the second one is kidney. Kidneys are divided into two anatomic parts, the parenchyma and the sinus. The parenchyma is subdivided into two parts, the cortex and the medulla. I see some pyramid and papilla in the medulla. The sinus is filled with fat, so you will see the hyperechoic region in your ultrasound, and cortex will be the hypoechoic region. It's called the double density. Next, we have the image for this. To image the right kidney, you place your probe coronary plane of the patient about the mid-axillary or anterior axillary line at the level of the xiphoid process. In this place, maybe you need to rotate your transducer 15 to 30 degrees counterclockwise to locate the true long axis view of the kidney, because the kidney is located oblique. It's not a really longitudinal to. It's not really parallel to your body. It's a little oblique, so you have to rotate the transducer a little. And until you find your long axis view, you can turn it counterclockwise 90 degrees to see its transverse view. It's the right kidney look like. Most of the time, we use the lever for the oxygen window for better view of the right kidney. It's the double density. The sinus hyperechoic in this, and the cortex hypodensity alternate. This left kidney is posterior and superior than right side, so the same way. But remember, maybe you have to place the transducer and the posterior axillary line and superior. You can ask the patient to hold the breath in the maximal inspiration to move the left kidney down to decrease the rib shadow. Is the left kidney look like? It's the same. Left kidney, right kidney, yes. Cortex, there's maybe it can find some medullary pyramid here in the sinus, the hyperechoic region. What are clinical indications of us to do the renal ultrasound? The ultrasound is not like the renal ultrasound done by the other doctor. We did this ultrasound for some specific questions. So the first indications of us is maybe the acute flame pain with suspect renal colic. So you want to see if there is hydronephrosis or not, if there is obstruction. And the second indication may be acute kidney injury, since that post-renal cause, bladder obstruction or urine retention is the leading cause of acute kidney injury. So you can see this by ultrasound. And the last use is maybe trauma patient. Trauma patient did a FAST, right? But the FAST is to detect the free fluid, not the kidney parenchyma itself. But if you use the ultrasound more and more, you can use the ultrasound to detect the parenchyma injury. And acute hydronephrosis and renal abscess, you can differentiate this in renal mass. Acute flame pain is the primary indication for us. It's for obstruction or not. Means that you want to see if there is hydronephrosis or not. If you see the hydronephrosis in kidney, remember to scan the bladder, because the bladder distension, bladder obstruction is the main cause of the kidney obstruction. Sometimes if you place the Foley catheter, the bladder distension disappear and the hydronephrosis just disappear. In the second, of course, acute flame pain, you have to exclude the abdominal aortic aneurysm as mentioned yesterday. So in my practice, if the patient age is larger than 50 years old, I scan every patient in acute flame pain for abdominal aortic aneurysm. Every patient, if he presents with acute flame pain, right? This is the hydronephrosis look like. You can see the hyperechoic region in the sinus, but it is occupied by some hypoechoic region. It's called the hydronephrosis. The hypoechoic in the hyperechoic, right? So you can see, maybe if it is a mild hydronephrosis, you can see three layers, the hypo, the hyper, and the hypo. There's some severity classification for hydronephrosis. First is normal and mild, moderate to severe. Mild is just a little hypoechoic region in sinus, but the intake, cortex, and pyramid structure. The moderate means that the dilation of the calyx and the obstruction and bonding of the pyramid. So you may see some bonding here, and it is called the classic bear claw appearance because the pyramid is also bonding to it. Bear claw. Yes. Okay. The severe hydronephrosis is total distortion of the renal architecture, and maybe you just only see the thinner cortex only. The sinus is just replaced by severe hydronephrosis, or in the kidney is the hypoechoic region. This is the kidney stone. Kidney stone actually is just look like the gallstone. So there's an occult shadow here also. And this image shows multiple kidney stones here, yes. Okay, so you can see the case, 48-year-old man with right flame pain, As you can see, this moderate hydronephrosis here and hydrourator. Sorry. Hydrourator. And it's so lucky for this patient, we trace the hydrourator and find the mid-ureteral stone. So you can see this hydrourator here, right? Goes to here, and a stone appears here. Hyperechoic stone with upper shadow. However, you have to know that the ultrasound is not good for detect the ureteral stone. So don't spend too much time to find it, trying to find it, right? For diagnosis, you have if you want to diagnose the obstructive uropathy, for detect the hydronephrosis necessary. If you have time, you can find it. But if you don't have time, don't try it. Okay, this patient also have multiple stones with acute pain. The stone character is a little different because there's multiple stone, and you can see the lot of acute shadow behind the kidney stone and also the hydronephrosis. Sometimes we call this kind of stone the stay-home stone. Stay-home. Yes. And also the common finding of the kidney ultrasound is the renal cyst. The renal cysts are common finding and usually benign, but renal, the malignancy or complex cyst maybe looks like the same. So you have to remember several criteria of renal cyst, and these criteria must be all fulfilled. The renal cyst must be thin, smooth, round or oval, and no internal echoic or solid elements, well-defined margin, and the posterior with the posterior enhancement. If the above criteria is not fulfilled, you have to consider that this cyst is not a simple cyst, maybe complicated cyst, complex cyst, or renal malignancy. So further survey is needed, maybe CT scan. So this image shows the simple cyst with the posterior accretion shadow. You can see posterior enhancement. Posterior enhancement means that the area behind the cyst is lighter than the others. That's just a simple renal cyst. Okay, let's summary. To remember the morphology of hydronephrosis, the hypoechoic region in the hyperechoic sinus. To differentiate the cyst or the mass lesion, remember that the simple cyst must fulfill all the criteria. And if you see the hydronephrosis, remember to do the bladder scan, because the greater distension or obstruction is the common cause of hydronephrosis. Okay, thank you.